Okay, morning to everyone. We are going to start discussing renal cell cancer. The first talk is going to be given by Dr. Ferran Algaba, well known from us all, that unfortunately doesn't bring the yellow lace from Catalonia, but perhaps he has on the pocket.
But this is not a political situation, please.
Well, I know. So he's going to talk about histological subtypes and treatment and the relation between them and the role of the pathologist.
Exactly.
Thank you.
Well, good morning, everybody, and thank you for the invitation to join you in this course. And I would like in this short presentation to consider the importance or the impact of the morphology in the treatment in renal cell cancer, of course. And I would like to start with one idea. What is the objective of any classification in medicine? Well, it's not difficult in medicine because the idea is to distinguish different biologies, with the idea, of course, to differentiate evolutions and probably different kind of treatments. That means that the classifications are in very close relation with the treatment, not in the fashion, or in the kind of treatment in this moment, especially in cancer. And it's very easy to understand that when the unique treatment in renal cell cancer was the surgery, probably this classification is sufficient. Clear cell carcinomas, granular cell carcinomas, a little more aggressive, papillary, multifocal, and of course the spindle or sarcomatoid, very, very aggressive. And this was the sufficient idea. But we are pathologists, and the pathologists, we are a very peculiar people. Do you know the pathologists in the room? And that means that we are always looking for some kind of difference, and we can see here 4 different clear cell carcinomas that are 4 completely different clear cell carcinomas. But not only in clear cell. It is possible to see in granular cells and in papillary renal cell carcinomas. That means that little by little, when as a pathologist, we are looking for the basic cells, clear, granular, papillary, and spindle, and we consider these some morphological differences, we can see there are many different subtypes in morphological point of view. And this is very interesting. That means that little by little, the WHO decided finally, in 2016, finally, until this moment, I don't know in the next future, to consider that there are not only clear, granular, papillary, and spindle or sarcomatoid, there are all of these subtypes. Well, maybe for some time, the urologists and the oncologists consider that this is a mania or obsession of morphology, and probably may represent this in some circumstance. But when was found in hereditary cancers that there are some different genes in relation with these hereditary or familial cancers, and more than this, that some of these different genetical or chromosomical changes are also present in sporadic cancer, more or less frequently. And this represents that in one moment, in this classification, we can see that there are many different genes in relation of these morphological subtypes. And more than this, when we consider the basic clear, granular, spindle, or papillary, there are different morphological and genetical types. What's the importance of all of this? That in these subtle changes or modifications of morphology among one common cellular type, there are differences in biology. This was important when we consider the new treatments, targeting treatments. For instance, when we consider this pseudoepoxic pathway in relation with epoxic factor accumulation, we can see that there are the clear cells, and one of the clear cells is not in relation with this. And probably this is completely different, and this is really, in this moment is considered, this kind of clear cell papillary renal cell carcinoma, that is just a description of the lesion, is completely different of the others. What is important is, for this, what happened in the pseudohypoxic pathway? There are deletion or loss of short arm of chromosome 3. That means that in one moment, the stop of the hypoxic factor is stopped and has accumulation of this hypoxic factor. This accumulation of hypoxic factor through stopping or stimulation of CMYC has an induction in the nuclear, and this produces vascular endothelial growth factor, plaquetal derivative growth factor, epithelial growth factor. And this vascular endothelial growth factor increase and has stimulation of the endothelial cells and the plaquetal derivative growth factor to the pericytes. That this is neoangiogenic growth. But not only this, the epidermal growth factor stimulates the proliferation through the RAF-RAS and also through the mTOR pathway. Well, all of this is very interesting because this has all the different new treatments stopping in some different levels. And it's very, very, very interesting when you consider that, for instance, the sunitinib has stopping the receptors of the neoangiogenesis. And when we consider this, the sunitinib in metastatic cases in relation with the expression or no expression of the CMYC, we find this in one series of 83 patients, metastatic patients, clear cell carcinoma, classic clear cell carcinoma, has a different survival if there are no presence of no expression in the nucleus of CMYC. That means that in some way we can see some markers, but not so strong for every day. This clear cell, this is the classical clear cell. In the von Hippel-Lindau disease, is 100% happen these alterations in the gene. But in the sporadic form, more than 70% happen similar situation. This is important because can be used the same treatments. But more refinement, more scrupulosity, because there are also I'm looking here to avoid these different mutations in different genes. And this is important because, for instance, the mutation in von Hippel-Lindau has different missense mutations, and may be considered that probably there are different treatments depending on these missense mutations. And also, patients, the 30% of patients without this von Hippel-Lindau inactivation probably are more aggressive than the others in the sporadic form. And more than this, patients with mutations in both PRM and BAP1 has worse prognosis. That is only one mutation. That means that it's not only one aspect. There are many aspects in prognosis and also in some treatments. Well, what happened with the papillary? Well, the papillary, we have these different morphological subtypes. This is the papillary type 1, that the familiar form is the papillary hereditary form. This is the type 2, is the more difficult and complex. This is in relation with the hereditary leiomyomatosis, and also the collecting that is completely different but has papillary in some instance. There are two different pathways. One is the CMYC, and the other are the pseudohypoxic pathway, but through Krebs circle. What happened with the papillary renal cell carcinoma type 1? In sporadic forms, only 10–15% have similar to the hereditary. That means that is a low incidence of these changes. But the pathway is completely different. The pathway is in relation of overexpression of hepatocytary growth factor stimulation and has a very close relation with proliferation through mTOR. It's completely different than the other. But what happened with the hereditary form, with leiomyomatosis hereditary form? Has a problem in the fumarasa. In the Krebs cycle, we can see here that the fumarate passes through the fumarasa to malat. And if we have this mutation here, this increase stops and has also a similar pathway. in another way, similar pathway that the loss of chromosome 3. Well, and there are different blockers. We can continue with this difference, and for instance, the papillary renal type 2 is more difficult, and some people has the idea that not necessarily 100% has relation with the fumarasa. Well, this looks complex, it's complex, but it's in relation to understand the different targets. For instance, in chromophobe renal cell carcinoma, in cases in relation with Brit-Hot-Dubé, has these changes, and only 5% of sporadic forms of chromophobe renal cell carcinoma have this pathway. That means that the different possibles of targeting are completely unuseful in classic sporadic chromophobe renal cell carcinoma, but 23% has some targeting with mTOR pathway. Well, and the other subtypes are different. For instance, the collecting duct carcinoma, some oncologists consider more in close relation with urothelial cell carcinoma, and probably some chemotherapy for urothelial cell carcinoma can play some role. The renal medullary carcinoma is so aggressive, no time even for treatment. There are the relation, the translocation carcinomas has in relation with mTOR pathway, and these are very low aggressivity and has question mark about the targeting treatments, and there are new entities and different positions. Well, all of this is to explain the importance of the subtypes, but there is a very big problem, the heterogeneity of these tumors. And this heterogeneity is so frequent. For instance, in clear cell carcinoma, classical clear cell carcinoma is the most frequent, around 70% has different heterogeneity inside the tumor and in the metastatic. But the good news is that this heterogeneity is in different genes, but in von Hippel-Lindau mutation is continuous and probably is one of the good targeting element for any subtype, even in this heterogeneity. And even in sarcomatoid, when there is a bad differentiation, the sarcomatoid component has a similar gene alterations that the truncal origin of this sarcomatoid. And one of the important aspects is that it seems that in the evolution of the renal cell carcinomas, what happened is a neoantigens appears a lot of neoantigens, and this can be interesting for the new treatments, the immunotherapy. There are many areas to act in immunotherapy. Is out of my topic of my knowledge, of course, but it's important to consider that, for instance, immunotherapy in renal cell carcinoma has in relation at this moment with CTL4 and with the PD-1, PD-L1. And what's the way of action? This is the normal, that the tumor cell stopped the function of the T cells, and what's happened, we can block the receptor or the action and has these different markers and these different treatments. Well, and has real correlation, it seems, with the targeting treatments. And the most next possibility that is just under research is the microvesicles and the exosomes and the utilization of these as markers. Well, the conclusion is that we as pathologists, we need to have a very clear and precise diagnosis of the subtype. Of course, the main treatment is in renal cell carcinoma is continuous the surgery. And in metastatic, probably when it's oligometastatic, probably the surgery is also a helper. But when it has a very extensive metastasis, the oncological treatment is the indication. Well, it's important for this reason, or even mandatory, I think, needle biopsy, especially in cases of metastatic situation or in cases of cryotherapy. When you are doing cryotherapy for one tumor, we don't know, unfortunately, what can happen in the future. And we need to know what is the histology of this patient for some circumstance of metastasis after this cryotherapy in the future. That means that the role of needle biopsy that can we consider. The other is that the pathology, we must be very scrupulous. Not all clear cell are clear cell carcinomas. Not all eosinophilic cells are chromophobe and so on. We need to look for and to be considered the close relation with the new treatments. Of course, the most important targeting treatment is in relation with vascular endothelial growth factor and mTOR. The heterogeneity is important, but probably in this moment is not the big problem in these new treatments, but it's important to consider cases without response. And immunotherapy is one future that is necessary to explain later. And unfortunately, even we can have some markers of response. These markers in this moment are not useful for every day. Thank you, and I think that the most important is we need to interchange opinions among the different specialists in relation with cancer and with relation with the patient. Thank you.
Thank you very much for your nice talk and nice review of all the aspects relating to renal cell carcinoma. I don't know if is there anyone wants to ask Professor Algaba? Okay.
Recently I had a case of a patient who had clear cell renal cell carcinoma 2 years ago, and now he presented with bone metastasis. And the biopsy of the bone metastasis had a metastatic carcinoma. I know it's a renal cell because it was PAX8 positive. But then as we were looking for the origin of the tumor, the first markers we asked also for CK7 and CK20, and the tumor was CK20 positive also, and no clear cell morphology. So we went back to the primary tumor, which was in our institution, and of course it was a renal cell carcinoma, but there was a component that was overlooked, maybe 5–10% of the tumor that was not clear cell morphology. Yeah. A little bit like tubular sarcomatoid morphology, no specific entity, but we did CK20 on that component and it was positive. So I think it's curious to, because if we go into the literature, most places say CK20 does not stain for renal cell carcinoma.
But recently is presented some kind of indifferentiated with a lot of back walls that has cytokeratin 20 positive. I don't know if this specific cytokeratin 20 is basic for this, but you explain one very interesting element. The original has some overlooked in this moment that is possible to understand, and it's easier to see when you are looking in retrospective the sarcomatoid component. This is very important, this information, because any subtype, even the most or the less aggressive subtypes, if there are some component of sarcomatoid, be careful, sarcomatoid, not a spindle, really a spindle with anaplasia, it must consider and inform to the urologists and oncologists because this is one of the aggressive possibility. Recently, not in our center, we considered one case of chromophobe renal cell carcinoma. Unfortunately, it was the mother of one another doctor. And all the people said, well, don't worry, because it's chromophobe, low grade, and so on. And 1 year later, the lady is with metastasis. Looking once again, surrounding the vessels in a minimal expression, there were a spindle sarcomatoid component. That means that is necessary, I explain here a general idea, but we need a very precise observation, explanation of all the findings, be careful with the sarcomatoid components, and a sampling, a very wide sampling, because maybe has different areas. But strictly the cytokeratin 20 is now starting to appear in some cases, but I don't know exactly the meaning of cytokeratin 20.
Any more questions? I have a question regarding the role of the pathologist in the new guidelines of the European Association of Urology, because now immunocheckpoint inhibitors are becoming the standard of treatment on metastatic renal cell carcinoma. And although in renal cell tumors, they don't ask us to do stains for PD-L1 like in lung, it's still plausible to understand that we can add some information regarding, for example, the immunoscore that has been done on colon cancer, how many CD8, CD3 cells are positive. What do you think about these?
Yeah. Uropathology, in urology in general, all these advances in lung, melanoma, and colon are not introduced. Even in bladder cancer, that is more studied, this immunotherapy has a big discussions about if it is useful, the PD-L1 marker in the second level, in the second line, or in the first line, or there are many. In renal cell carcinoma is just at the beginning, and Elizabeth maybe explained it in some moments about this aspect. It's not useful, it's not used in this moment in renal cell carcinoma, because it seems that even with minimal expression of PD-L1 is sufficient, 1% is sufficient for use this immunotherapy. But we are just in the start, and I don't know what is but not yet.
And the use of the immunoscore that has been, developed and has been promised as a revolution for many tumors, even on the
Exactly.
classification, what is your feeling about it? Because sometimes we see a lot of inflammatory lymphocyte infiltration in tumors, and sometimes we don't have in other similar tumors no inflammatory cells at all.
We don't use, but it is every some years has the fashion of this inflammation, and tumors that classically has infiltration, for instance, seminoma and so on, for a long time was looking for more quantity of infiltration or less quantity. I think that this is also in relation with the treatments. Many years ago, the immunotherapy treatments are very soft. For instance, in kidney, interleukin and interferon, but not sufficiently strong. Probably with this new, we can re-read for the CD8, some different CDs, and to consider what is the proportion. But only in this moment is under study, is just speculation.
Okay, no more questions for Professor Algaba. We are going to continue our discussion. Thank you very much, Professor. And the door is open to our colleague, Dr. Sérgio Barroso, oncologist, medical oncologist. Is there a place for TKIs in this moment?
Good morning, dear colleagues. I want to thank to Dr. Cláudia da Silva and all the organization this kind invitation. My topic today is to discuss the role of TKIs as first-line therapy in advanced renal cell carcinoma in the era of immunotherapy and the new target therapies. Okay, it's all right. Well, as we know, we have different kind of therapies for this disease. In the 90s and the latest 90s and early 20s, we have cytokines as the main medical therapy for this patient. And After this, we have the VEGF drugs and mTOR drugs that are the standard therapies for these patients. More recently, we had new drugs, new TKIs, and the immunotherapy drugs that has shown clear efficacy for these patients. And probably they will have a clear place in the near future for the treatment of these patients. When we have to decide which therapy we choose for these patients, we have to pay attention to patient-specific factors and also to agent-specific factors. Prognostic index is one of the major aids that we have to choose our therapies according to the risk factors that the patients had. Comorbidities are very important too, because all these new drugs have different adverse events, so we have to choose the right drug for the right patient. Age, of course, is important, and the quality of life balanced with the tolerability are very important too. And one aspect that is very, very critical is the adherence to therapy, because many patients don't take these medications in the right way, and this could lead to different efficacy of the treatments. We have also agent-specific factors that are very important, because these drugs have different toxicity profiles, and we have to adapt to the patient that we have in front of us. The experience we have with different drugs is also very important, because the management of the side effects and all the therapy is different according to this experience. And then the availability and the costs of the therapies are also very important. Finally, route of administration and dosing schedule are also important factors. The EMDC is one of the most important risk assessment tool that we have, and we define, as you know, patients according to a more favorable, intermediate, or high risk. And this is very important because we know that these patients have different survivals according to those risk factors. And we can see that in the favorable group, we have an extended survival comparing with the risk for patients. Well, we use TKIs since the latest 90s, and we have a very, very good experience with these drugs, and nowadays they are the standard of therapy for many, many of our patients. So the question is if today this TKI therapy is still standard or not. One of the most important studies that we have is the COMPARE study that compares two of the standard TKIs, pazopanib and sunitinib. This is a phase 3 study comparing these drugs in the usual dose and schedule that we are used to have. The results of this study are very interesting, and they showed that both drugs are very similar in terms of efficacy, in terms of PFS, and in terms of OS. So they are similar. The difference between these two drugs is mainly related to different toxicity profiles. There are some important difference between the two drugs, and this is very important because we have to adjust the therapy to the patient that we have, and one patient can benefit more with one drug than with the other according to the comorbidities and according to the toxicities he have. More recently, another drug has come to our practice. One of the most important studies is this cabozantinib study. This is a phase 2 study comparing cabozantinib with one of the standards, the sunitinib. as we can see, we have different overall response rates and PFS that favors cabazantinib. And this is for patients with intermediate and poor risk groups. So this is one of the new alternatives to these patients in first-line therapy. This is the curves. The median PFS for cabazantinib is 8.2 months, and for sunitinib, 5.6 months. The toxicity profile is for sunitinib is what we expect from this drug that we know very, very well. And for cabazantinib is also a toxicity profile that is very manageable too. Probably the hematologic toxicity is a little bit more frequent with cabazantinib than with sunitinib, particularly with thrombocytopenia. Another study that has come to our knowledge recently is the Checkmate 214. This is a study of combination of ipilimumab and nivolumab, two recent drugs in the immunotherapy field. This is a study, phase 3 study for naive patients with renal cell carcinoma, good performance status, and as we mentioned before, Pedro Oliveira talked about this, the PD-L1 expression was tested. Nivolumab was administered in the usual dose, and ipilimumab too, and sunitinib with the standard schedule. The response rates that we have obtained in this study is as follows in this slide. The complete response is more expressive than with nivo and ipi than with sunitinib. The partial response too. So we have more intense responses with this combination of immunotherapy drugs. In terms of PFS, we have 11.6 months of PFS for the combination and 8.4 for the sunitinib arm. And for the overall survival, we have 20.6 months for sunitinib. That is in line with the overall survival that we are used to see with this drug. And to nivolumab and ipi, it was not reached in this analysis. So this combination could be an excellent alternative for these patients in first-line therapy. In terms of toxicity, the toxicities were for sunitinib as we expect, and for nivo and ipi, according with what we know about the toxicity of these two drugs. In terms of the favorable risk group patient that was evaluating this study too, we can see that the difference between the two arms are not so different as we can see in the other two groups. In terms of toxicity, we have to pay attention to the immune-related toxicities that are very typical from these new drugs, including diarrhea, colitis, pneumonitis, hepatitis, and nephritis, that are potential effects that we have to care with attention. Well, TKI is still first line. They are the standard of care for renal cell carcinoma first line in this era of new drugs. For patients with favorable risk, the optimal treatment therapy is still sunitinib and pazopanib. They are the standard of care. cabozantinib was approved. There are no specific indication for according to the risk groups, but we know that in the trial the patients were in the intermediate and the poor risk group. For patients with intermediate and high risk score, these new treatment options are a possibility to use cabozantinib as one of these alternatives, and the combination of nivolumab and the ipilimumab with this encouraging data from the Checkmate study can be in the near future a very good alternative too. We have to balance the efficacy and the toxicity of these different treatments because they have some potential high-grade toxicities. The management of these patients is evolving today in the very, very rapidly, and we have to choose the right therapy for the right patient according to the characteristics of the drug and according to the characteristics of the patient. And these two factors are very, very important. All these data are in the more recent guidelines. The ESMO, the NCCN, and the EU, they all present this data and recommend these therapies for these groups of patients. So I have to say that, in my opinion, the TKI still has a very important role in first-line therapy of these patients, and today they are the standard of care. Thank you.
Thank you, Dr. Barroso. Any questions for the speaker? I think that the hand message is very important because we see very tumors that has different compartments. One tumor with a big tumor with many metastases on the beginning, and some other times we have small tumors, and later on we have one little metastasis in the lung or in a bone, and so on. The natural history of this kind of tumor is quite different, and I think that we have to choose the best treatment for this patient is in our front and to the natural history. Do you agree with this?
Yes, I agree, because renal cell carcinoma has different kinds of evolution, and for the same tumor, apparently the same tumor has different forms, and all the comorbidities that the patient have and the tolerability that the patient have is commonly very different from others. So we have to tailor the therapy for each patient that we have.
Yes, I agree.
I have a general question. Don't you think it's time for you oncologists to stop talking about renal cell carcinoma and start talking about clear cell type renal cell carcinoma? Because I believe that people are mixing up like orange and Turanja. They are similar, but they are completely different in terms of response to treatment. And when we are talking about, or when we are reading about things published on renal cell carcinoma, is everything together under the same umbrella, you know. And I believe that, as we have seen from the previous talk, that's not the case.
Yeah,
so
you're right. You're right. All these data are most of these data are for.
The problem is that most, but you know, the purity of some of the trials that have been and the guidelines that have been published, in some way, are compromised because they are including also tumors which are not of the clear cell type. For many years, we just had a code, the same code for renal cell carcinoma, covered a lot of entities, but now precisely the code 8310 is just for the clear cell type. And so we should address only clear cell type morphology tumors and not talking about renal cell carcinoma, because renal cell carcinoma is any carcinoma that occurs in the kidney.
Right.
So,
You're right. And most of the data that we have is in clear cell carcinoma. So when we have a different kind of tumor, we have less data and we have a weak evidence to decide the best therapy for those patients. But you are completely right.
I'd like to ask a question. In this era with TKIs and immunotherapeutics, in your practice, do you still arrange for a nephrectomy to be performed in a patient with a large primary tumor and multiple metastases? And does the density of PD-1, PD-L1 expression influence your choice of first-line treatment?
Yeah. That's a very good question and difficult to answer. Most of the data we have is in patients with previous nephrectomy. So when we have a patient, as you said, it's a difficult decision. But my impression is that in patients with large tumors and metastases in lung or in other organs and high expression of PD-L1, perhaps we can treat them with the immunotherapy and nivolumab as an example, and not submit the patient to nephrectomy. But we have to demonstrate this because we are, by now, as I know, we don't have evidence to support this. So it's a question that we have, and we discuss that when we have this kind of patients, but we don't know. We don't have evidence to support, but it's my feeling that probably it's a good option not to submit this patient to nephrectomy, because if this therapy are very efficacious, so perhaps we don't need to submit the patient to surgery.
Any more questions? Myself, as a surgeon, if we can take it off the tumor, we'll go on. Since it has metastasis, but it is feasible to do the nephrectomy, I think it's better to do it. If there is no comments, I think that is okay.
Yeah, no, it's a compelling question. Dr. Ragavan always seems to ask tough questions. At our institution, we've done the same thing. We've really promoted taking out the kidney up front, but I mean the complexity that lies into a couple thoughts. One, in the immuno-oncology era, which really started out with high-dose IL-2, of course the data does support cytoreductive nephrectomy. And then in the target era, as was mentioned in that excellent talk, it was further promoted. But I think the concept of primary response in the kidney is an area of that is ripe for clinical research and continued effort. I mean, we certainly have anecdotal stories of anti-PD-1s responding in the kidney, and it is my belief that it probably does have a better response primarily, but it's uncertain, and certainly when you look at the neoadjuvant data in the targeted space, it's a very mixed response. Sometimes it works, sometimes it doesn't. And then I think the surgery, the complexity of the surgery is another thing that we talk about and are still trying to understand. I mean, certainly if you can laparoscopically take out the tumor, it's hard to argue in this gray space to not do that. But really it comes down to the patients that have very advanced disease, that the actual surgery looks very complex. But right now in 2018, we certainly promote, if you can take out the tumor, to take it out and then treat following cytoreductive nephrectomy. But certainly an area that is undergoing research now. There's two trials looking at this, and I think over the next couple of years will shed some light into that space.
Thank you so much. Okay, the next speaker is going to be Professor Luis Costa from the University Hospital in Lisbon, and he's going to talk about combination therapy in metastatic renal cell carcinoma.
Hello, good morning. Thank you so much for the invitation. It's an honor. I have to do a disclosure. I'm going to speak mostly about clear cell carcinoma, since we have a pathologist in the table and many pathologists over there. Okay. So I think I totally agree with my good friend Sergio Barroso that right now the evidence points still that we should use TKIs up front. Of course, all the oncologists like to know what to do first, what to do next, what is the evidence, how can you compare, and so on. It seems to me that until now, what we can say is that for second line, there are some evidence that also can improve survival. That's why the strong arrow looks the preferred option. So nivolumab is here, cabozantinib is over there. Not exactly the same drugs, as you know, don't have the same mechanism of action. They can have different profiles of toxicity. But what is important to know here, because my talk is about combinations, is that this is the status right now. And the status right now could also compelling us to say, should we combine or use sequentially? What is the advantage for that? Sequentially, we can say, should we start with the TKI or with the IO, so immuno-oncology? We can maybe believe that using sequentially the toxicity will be less because combination usually leads to more toxicity. But we also could think about, and sometimes this is a trend, a cultural trend, think about that on first line you may have maybe fast response with TKI. I don't know if that is true. I'm going to challenge your mind about that. And on the other way, with first-line IO, you may maybe benefit asymptomatic patients with low disease burden, those patients that seems to have long time to live, and maybe we can have a longer response with the IO. Okay, so there is still trials ongoing with these testing these combinations and these, not combinations, the sequencing between IO TKI or IO. I'm not going to talk about them. So this is just a background before I start to talk to you about combination. Why combination? Well, I think everything that we do as doctors, we need a reason to do it. At least we need to be convinced that we are doing something for one reason. And what is true is that we know that angiogenesis, which is a hallmark of all renal cell carcinomas, we know that angiogenesis can promote a immunosuppressive microenvironment in the tumor. Different levels of evidence, looking to dendritic cells, looking to the expression of inhibitors, checkpoint molecules, and so on. Even the increased expression of Treg cells in the microenvironment. On the other side, you can see also that angiogenesis and immunosuppressive work hand-to-hand in the tumor microenvironment. Why? Because immunosuppressive cells, by their own, can be the source of VEGF. For instance, type 2 macrophages, they are the source of VEGF. So they also can contribute to new angiogenesis. And there is a very recent review just came on these very nice Nature reviews, where you can see that increasing evidence looking for both sides. Hypoxia induces the secretion of cytokines and chemoattractants to increase recruitment of immunosuppressive cells. And on the other way, the endothelial cells of tumor vessels express lower levels of cell adhesion molecules, causing endothelial anergy and thereby reducing the ability of T cell effectors. What that means that probably we have here, at least mentally, a room to combine both treatments. And that's what we're going to start to talk now about now. IO plus IO or IO plus TKI, two options. IO plus IO, such as nivolumab plus, for instance, ipilimumab. We know that this can improve the efficacy of immunotherapy, but it's more toxicity. It's non-redundant pathways. We know that by PD-1, PD-L1 tackling, there is an excellent maybe is too strong. It's a good therapeutic index. PD-L1 may be predictive. I don't know if it is predictive of the treatment or predictive of a group of patients with a worse prognosis that benefit this kind of treatment. And on the other side, you can think about this by doing IO plus TKI, you may probably explore the synergy, improve the efficacy versus single agent, and so on. There is also interesting data coming from other trials that were not designed to test combination, but just sequencing. Just sequencing between pazopanib and sunitinib, or vice versa. In 80 of these patients of this SPICY study, there was the possibility to measure the levels of total monocytes and, for instance, also pro-angiogenic monocytes. And what is interesting to see that either both drugs can some way diminish the incidence on the microenvironment of immunosuppressive cells. So means that maybe they can help to prime the tumors, also even to a better response to IO. This is not only the evidence that we have, I hope this is working, okay, not only from Pisces study, but there is also other evidence already published, also showing that either with sunitinib or bevacizumab, you can change the microenvironment in the tumor and look for the expression of either CD8, CD4, Treg cells, and so on. Okay, we're not going to take too much detail on that. Let's go and see to the evidence. Don't have to take so much time with 214, checkmate, because Sergio just already explained you. So I'm not going to explain you the trial, but here we have one combination with single therapy testing. As you know, the overall survival was better with the combination IO-IO, but this should be stressed is for the intermediate and poor risk patients, not for favorable risk patients. And on this group of the patients, the PFS is superior, and what is interesting, the response rate, and that's why I was telling you some slides ago that I'm going to challenge the question of the response rate being with higher with TKIs. Here looks that the response rate seems to be higher, or it is definitely higher here, at least statistically significant, with the IO-IO versus sunitinib. And we must pay attention that on the trial, although this is true for the IMDC intermediate or poor risk, on the opposite, the patients with the favorable risk, all the things seems to point that the monotherapy with sunitinib seems to be better. So I think here this is an important message that we need to understand how to do in the future. So maybe combination seems to be first message important for those patients with intermediate and poor risk. The toxicity was already showed for you from Sergio. So my reading is that we have less toxicity with IO compared with sunitinib, but strong toxicity is worse with immunotherapy, in my opinion. And that's why you have more patients discontinuing the treatment with immunotherapy, and numerically you have more treatment-related death in the immunotherapy. So immunotherapy seems to be better tolerated, but if you have grade 4 toxicity, this could be very complicated in our patients. So it demands teams that are really prepared to handle with that. There is more evidence looking for the combination, and here a phase 2 trial, the Emotion 150. And here, I don't want to explain you on detail the trial, just to say that these patients, naive from treatment, metastatic renal cell carcinoma, they were randomized 1:1 to either immunotherapy plus bevacizumab, and atezolizumab is an anti-PD-L1, not an anti-PD-1. It's different. Atezolizumab alone or sunitinib, and then they could cross over the other two arms, the last two arms, to the combination if there was progressive of disease. And on patients that are PD-L1 positive, the PFS seems to be favorable to the combination atezolizumab plus bevacizumab. But this was a phase 2 trial, and that's why here in late 2017 we were expecting a lot of results with the combination, and among these was Emotion 151, and these are the results also of Emotion 151 that was just presented recently at ASCO GU. So this is now a phase 3 trial. On this phase 3 trial, we are testing the hypothesis of combination atezolizumab plus bevacizumab versus monotherapy with sunitinib. Large trial. Again, the patients were scored not only for the IMDC group, but also for the expression of PD-L1. And as you can see, the progression-free survival in those patients which tumors were expressing PD-L1 was in favor of atezolizumab plus bevacizumab, so combination IO versus together with the anti-angiogenic seems to be better. Overall survival seems also to be better. And the summary for the side effects seems to be interesting for this combination. PD-L1, the antibody against PD-L1 may have a different toxicity profile compared with the anti-PD-1. I can have then discuss with you if there is time for that. And what is interesting in my perspective, in my reading, is that the time to symptom interference with activities was measured in this trial seems to be in favor of the combination. So I think we have here an interesting combination that seems to be relatively safe compared with sunitinib and with more efficacy. There is also combinations in the same spectrum, means so IO plus TKI, but here pembrolizumab together with axitinib in the early phase trial, so this is a very early, but tells you a sense, a flavor about the capacity of the efficacy, looking for tumor response, very high number of response on this trial, so more than 90% of the patients had some tumor shrinkage. And the conclusion from this trial was that this combination seems to be safe and tolerable in treatment-naive patients, but we have, of course, this is a early phase trial, we need to go forward with more evidence. So the phase 3 trials now testing the combinations are over there, and they are testing the combinations versus TKI alone, and here you have the comparator as with sunitinib. I show you the evidence that at least bevacizumab plus atezolizumab seems to be very interesting. Also nivolumab and ipilimumab, it's very interesting, particularly for intermediate and poor risk patients. We have other combinations that does not include immunotherapy. For instance, as you know, levantinib plus everolimus in second line seems to be an important option for our patients. We are participating in one trial, and we just yesterday saw, well, our first patient in this trial, you can see that in 9 weeks, a very nice response with levantinib plus everolimus. So we have other combinations to test. It's not only including immunotherapy. So my last 2 slides is to tell you that I agree that the first line still is TKIs here, and the second line we have, of course, IOs. We can have also cabozantinib. I think could be a good option for some patients, although I think it's more toxic than nivolumab. And we also have levantinib plus everolimus. I just show you can have very nice response, but there is also a different toxicity profile. But I think in the near future, we may have in first line either the IO combination, seems to be very important for intermediate and poor risk. Maybe bevacizumab plus atezolizumab. I don't know when it will be approved. Maybe covasam for some patients, particularly those patients with BMATs and particularly symptomatic. So, and then this will challenge us for what will be the second line after that. And my conclusions is that we can still improve our options for our patients. And maybe some of the patients in first line definitely will benefit from the combination. There is a good rationale for that. It seems to me that the good rationale points out to the combination between TKIs and IO therapy, checkpoint inhibitors. So I think this will be not the hand of TKIs. I think the TKIs may have a role in the future in the combination with immunotherapy, and that's it. Thank you so much for your time.
Thank you, Luis, for your excellent review. Is there any questions from? Oh, okay. Microphone is coming.
Thank you so much for your excellent talk. I have one question. We are stratifying the patients in intermediate, good and bad prognosis, and these are host-dependent factors. So this probably reflects a more biological rationale rather than, it's rather a consequence than intrinsic characteristic. And in the other side, we have different combinations with different methods of action. Don't you think that we should go deeper, like genome profiling, CD8 expression, PD-L1, immune profiling? Because I think that the classical stratification that is being done is not enough for us to select the patients. It's my impression.
Okay, I totally agree, Andre. And I challenged Dr. Daniel Hang last October when I did to do more or less the same kind of presentation, to include and to analyze PD-L1 on the IMDC classification. And they are doing right now this kind of analysis, what he told me. So I think PD-L1 will be a putative new factor to score the prognosis of the patients. And see, so more, you cannot look at it exactly as a predictive factor for therapy, but will be important to score the patients, and then we know if immunotherapy should be offered or not to those patients. Genome profiling, of course, I must agree, everybody agrees with that, but the only thing I can tell you with more precision is that PD-L1 is looked for to be included in the classification.
Okay, so I'm a little bit confused, but I'm a pathologist, so hopefully you can clear my mind.
I don't know.
So I'm assuming that treatment for clear cell renal cell carcinoma is different than non-clear cell renal cell carcinoma, right?
Yeah, depending. Well, yes, it is.
So going back to the case I asked Dr. Algaba before. So imagine you have a primary tumor, it's a clear cell renal cell carcinoma with a minor component, sarcomatoid, whatever, and then you know the metastasis is not clear cell renal cell carcinoma. It's not clear cell morphology. What do you do?
Okay, first of all, again, what we showed to you is what comes from the clinical trials, and the clinical trials requires pathology, does not require pathology from the metastasis. So we don't have a systematic analysis about what about if these patients you do a biopsy in the metastasis and it's different. So I could end my answer here, say there's no answer for that, okay? What I think is that if I have a patient that has a metastasis with a different histopathological behavior, I may consider that in my decision, but I don't have now evidence to say, okay, in these cases, it's true that you should change it. Let's gonna give you one example, okay. Let's gonna think that you have a clear cell carcinoma that metastasizes in the bone. Are we going to measure CMET to say that I'm going to use cabozantinib and not another treatment, or not? We don't do that in clinical practice. I believe this could be important, but we don't use that in clinical practice. So it's not only the histology, even using something that could tell you that the target is there, okay? So one thing is what we think it's logical, the other thing it's proved to be practical. It's different.
So most clinical trials disregard
They use the primary tumor as the pathology evidence, not the metastasis. And this Charles Swatton paper that Dr. Algaba showed to you, for instance, where they combined the analysis of the primary and the metastasis, was not really looking for different histology. It was just looking for phylogenetic tree comparing the primary and the metastasis. And it's interesting that the point R4 on the tumor was the only one that had really the same phylogenetic tree as the metastasis. Means that in a large tumor like 9 or 6 centimeters, just one clone will be responsible for the metastasis. So now I'm taking you back a question from the oncologist to the pathologist, okay? How can you be sure when you do a biopsy for a primary tumor that you are really analyzing the worst clone that will be responsible for the metastasis?
You're sure you're not analyzing everything.
Okay.
That's what you're sure of.
Okay. I think the liquid biopsy will help that in future.
Okay, thank you so much.
Thank you. Our next speaker will be Dr. Elizabeth Heath from Wayne State University in Detroit, Michigan, talking about immunotherapy and new targeted therapies.
Thank you. Oh, I'm so happy I can see you over the podium. Thank you so very much for having me here today. I'd like to also thank Dr. De Silva, the organizing committee, and of course Dr. Raghavan, again for inviting me. What a terrific place, and what I'm hoping to review with all of you today is the status of immunotherapy. As a person who practices in Detroit, Michigan, along with the wonderful Dr. Pontus, we're often tasked with, these are all really terrific ideas. How are you actually going to pay for these highly costly medications? And so theory and practice and trials sometimes don't all blend together. However, as what was just said, what's critical is knowing the data, because sometimes knowing the data will help us fight for your patients to get immunotherapy when perhaps it's not approved. So what I'm hoping to review with all of you today is to kind of review what is that role, and then what are kind of new emerging agents in this space that might take us in a whole different direction other than combinations. So what do we have? In all this wonderful discussion, really, the only FDA-approved immunotherapy in renal cancer today is nivolumab. So I say that because this often comes up. If your patient cannot qualify for a clinical trial or is not independently wealthy that can write out these $15,000 to $20,000 checks per dose for a long period of time, then we don't really have much to talk about. So where it stands today is nivolumab, and it's important to kind of know, in some sense, the mechanism. So and this is sad because this is exactly the conversation that we're having, not just amongst oncologists, but what was mentioned today is the multidisciplinary approach that we must have. And the conversation must include not just our surgery colleagues in pathology, but also our primary care physicians, because they often are left with us to manage the toxicities. So this interchange must also result in a meaningful dialogue with your primary care providers. Otherwise, they're not really sure what's happening. And we know this to be true because when we started with anti-angiogenics, the same thing happened. People with high blood pressures, rashes, they were coming back saying, what are you doing to my patient? So what happens is this conversation of they don't really know what immunotherapy means. You know, they treat rheumatoid patients perhaps with immunotherapy, but they're oncologic drugs. So we say they're fully humanized antibodies right here. PD-1, program death 1. I had a primary care physician say, I seriously have no idea what you are saying because it's not the language or the lexicon they're used to. So then you say, we're interacting. So I said, you know what? This is what my patient showed me. He came with this schema right from the website. He took it off and he said, this makes me understand what is happening, that the cancer is not being seen, or it should be. This is a normal immune system. And so here's my active T cell, doc. Why am I not seeing this tumor? Shouldn't it be that way? Oh, yes, well, that's true. But here we are. You now have an inactivated T cell and this kind of reaction. And then he says, oh, but if I get this drug that you're about to prescribe to me, this is exactly what's happening. So I say this because we have commercials running in the United States with people twirling and saying, I've got this cancer. It's a lung cancer commercial, same drug. Do you know the number of times I've had patients say, I just saw that commercial on TV right after the Lyrica commercial that says that drug will kill you. This one's gonna save me. So the context of how immunotherapy is being sort of marketed and developed is very multifaceted. It's actually really interesting, but it's affecting the way we practice because patients are coming in much more knowledgeable, much more demanding. They want this stuff and they know to go on the webpage. So I've taken this opportunity to also show this is the kind of material that I share with my primary care physicians. I say, you know what, let me just show you exactly what it is that we're talking about. And now you'll see why I'm including you into our discussion. So I challenge all of you to also think about that as you practice because there will be primary care physicians that are being affected. But this trial, and again, in this lecture, you might be checkmated to death. However, what's really important is to know there's so many of them, which is really quite interesting. But the only one right now that supports that FDA approval is this one. Again, second line, previously treated patients. So does that mean it's better, not better? No, it just is. These are folks that have had other therapies. Here it is, pill versus nivolumab. And as Dr. Motzer presented in the New England Journal paper, it actually worked as a second-line therapy. And here's your curves. And Dr. Pontus, you can put in more than just one laser pointer's worth in a difference for the overall survival. Because when you have to justify these curves, not just to ourselves, but to patients, but also to our colleagues to say, is this meaningful? These are very expensive drugs, not just in patient toxicity, but financial expensive, and also for the societal costs. So over time, as you're doing this, you get excited, but you really have to make sure that the differences are meaningful. But I think they may be. And as we've seen here before, you know, the toxicities are actually not bad. Now, it was pointed out that it could be bad, and it depends on what study you're talking about. And if you pick nausea, pruritus, diarrhea, decreased appetite, and rash, it's really not that bad if you look at the grade 3 or 4 toxicity. Now, you could say, well, could it be better? Well, of course it could be better. We just don't really know what we're doing. In some sense, we're quite naive ourselves in knowing how to manage these kinds of patients, where we've gotten very good at managing the oral inhibitors because they've been around a lot longer. But imagine us 10 years ago when we were bumbling saying patients are coming in. And my one story is I had a patient, same conversation. Why do urologists not want to prescribe oral medications? Because they got lots of side effects. But we have no issue in some sense of prescribing them in prostate cancer. So then you say, well, why is that? Well, it only takes one person in a wheelchair getting wheeled, past the urologist with his hands falling off and his feet and him crying because he's got rash everywhere for him to go, you can take that one. I'll take the next one. So it's quite important. But for us in practice, we get excited with numbers like this. These overall survival numbers are substantial. So how can you not get excited about that? Of course you can. But again, is it something applicable for others? So what I like about this trial, and since we are here in Portugal, is that these results hold no matter where you are in the world. So there is a distinction of the patients that are just from the US and Western Europe and the rest of the world. And as you can see with this graph with the hazard ratio, that there is a benefit. And there is an identifiable subgroup that we'd like to peg people in: one prior therapy, poor risk patients, less than 75 years of age, so that you could start to shape what that patient should look like, or what you envision that patient should look like. But I do want to highlight that, in a lot of ways, we sometimes make decisions about treatment based on that person or that patient in front of you. If there's a large tumor bulk, perhaps it's that patient with the lung lesion, and he or she is coughing or having problems with shortness of breath or any other issues like pain. You kind of maybe want a response rate that high. And you don't often see that, but I think the critical piece is that the objective response rate, when you really compare it, it's pretty substantial. So maybe you make a change in what you want to do, whether it's a second-line TKI or a second-line immunotherapy based on that. So what do we like in oncology? We like options. Maybe we've got too many options, but we like options because not every patient is the same. So you can use this information. And is this data holding? Because that was a paper in New England Journal in 2015. And yes, it is. It's holding because Dr. Sharma gave a very nice update in the 2017 Renal Symposium last year, which showed that this durability of response, it's holding. And we ask that question sometimes, not often enough in oncology, where we look at the best response, which may occur within 3 months. You get that bang, and then it doesn't last. So in this case with immunotherapy, the question of does it last? It's starting to be yes, that it is lasting, and I think that that's a great thing. And then the all-knowing PD-L1, PD-1, and oh, by the way, this is tissue we haven't even touched, and nor will I, so I'll never get me off the podium, about liquid biopsies. So in the days of figuring out not just PD-1 or PD-L1, but just genomic profiling using cell-free DNA, should we use that? And we know that data from Montipal basically says whatever you see in the bloodstream doesn't technically match what you see in the tissue, let alone the primary versus metastasis. So now we're really confused as to what of this process is the bad actor. But in nivolumab, it does not predict efficacy. So in my practice, I really try to do everything possible to get that answer quickly. And I would love it that we didn't check, because it's yet one more thing you have to do before you start a therapy, or it's a block of getting that information to the insurance company who demands that. So as we evolve, in some sense, I kind of don't want to know. And when I have data where really there's no difference with this group of patients with greater than 1%, 1% of PD-L1 expression versus less than 1, you see that it does not really help. So again, as been mentioned, that's not true in other cancer types that have this drug approval, but for this at least, it's not required. Now, the question again, clear or non-clear? In a lot of ways, it's been looked at, so let's just look at where that data is. In the Checkmate 374, it was a 3-arm trial. It was a phase 3b/4 trial. One arm was just straight nivolumab in clear cell. This is the arm that was straight nivolumab in non-clear cell, which, by the way, is still just non-clear cell. And then there's an other, whatever other means, but the other was a brain metastasis. So they had one guy with brain metastasis. So in this non-clear, which is, again, as mentioned earlier in the brilliant talk, on all the different subtypes, everybody got clumped into that one subtype. And here's your answer. First of all, about 65% were treatment naive. Why is that? Because we all know that the data is so mixed for oral inhibitors that if there's a chance to go on a trial with immunotherapy, patients are flocking to it. The median follow-up for this was 8 months. Here's your median duration of exposure, 3.3 months in the non-clear versus 5.5 months, in clear. So they're not holding. You're treating them, but right around the 3-month mark is where you would check if it's really working. With a CAT scan or other imaging, I don't think it's holding. Now, the weird part is there's really no toxicity either that's been reported. So maybe it's not working because it's either not enough, perhaps the dose isn't there, perhaps the actual target isn't there, but this is a completely unknown space. So as been mentioned before, we're in a percentage now where we obsess about the 1%, be it the genomic profile that spits out the 1%, or the 1% of PD-L1 status. But here, this is more than a 1% group, so we don't do it justice. There are trials in play looking at non-clear cell, but I don't think it's enough for our patients. But I want to bring up that one of the struggles also with immunotherapy is it's all great when we're looking at efficacy, and it's all great when we're looking at survival, but at what cost? So not just the financial cost, but the cost to the patient, and how happy is our trigger finger in figuring out how do we solve their issues? So I want to highlight there are new guidelines from ASCO that I'm not sure if the group is aware about, but Julie Bramer and others have put together really very organ-specific management, and I put the website here for you to access. And it's really key because it reminds me of the white paper that CTEP and other investigators wrote about kidney cancer many years ago about how do you treat hypertension. I mean, you wouldn't think you would need a group of us like here to figure out how to treat hypertension, but we needed to treat, we needed to get some semblance of what those guidelines are. So basically here, there's a recommendation that clinicians and others really need to learn to manage the toxicities. I always call them the itis brothers. You either have some colitis, pneumonitis, dermatitis, but the issue is what do you do with it? What's the standard? And I think the other issue is, what do you do with steroids? We haven't even talked about, once you start it, how scared are you? Like it's playing chicken with the toxicities. What point do you prescribe that all-knowing steroids? When the guy's on oxygen? When you're about to do a lung biopsy? When is it, right? So here's some guidelines that we all can now participate in terms of how you manage grade 3 toxicities. So I think if we start figuring out how to standardize our approach, the data might change, as I think it has over the years for tyrosine kinase inhibitors. And I just want to make sure that in general, any grade 4 toxicity should lead you to stop. And I point that out because I sometimes get a lot of referrals for clinical trials in patients that have had an immunotherapy, and they come to me too sick because they've had actually sequential immunotherapies or whatnot. They haven't stopped after a grade 4 toxicity. So I think it's clear to not take away that chance for them. But, You guys in Europe are way smarter than us. When you've heard about this data of first-line therapy, about Nivo, Ipi versus sunitinib, I just want to point out this, that you've already incorporated this highly successful combination in your guidelines. This was, I think, as of December of this past year. I think that's phenomenal. That's phenomenal because, this, again, needed to be incorporated in the States. The bars that we keep having to jump over of, does this meet that indication? What does the FDA think and all of that? This right here is highly, highly effective and promising combination. Boom, it's already in your category. So I wanted to highlight that and just say, wow, I'm in awe. But in terms of frontline therapy, this has already been somewhat of a standard default. So I wanted to put that in context. This mechanism, and we've seen the schema, but I like this because now, and explaining this to patients and or primary care providers, we're used to talking about right here. Now I show this schema, and I've shared this with them to say, yeah, there's others. This is a very scaled down view. You saw the other ones that have basically 30 of these targets. And again, that's a hint as to where this field is going to go. There will be many interactions that will be future disruption occurring depending on which company you're talking about. But why I think all of you have already incorporated that nivolumab and ipilimumab is because of this curve. I mean, this, when presented at ASCO GU, I think the room was, oh my gosh, I can't believe it's that big of a difference. It's that big of a difference with obviously some caveats. So we talked about the intermediate risk and all that, but when I look at this, we lump everybody together, right? So much like temsirolimus, when it rolled out, came out for frontline therapy, it's now relegated into that poor risk space. So is the comparator for a future trial maybe not sunitinib, but an mTOR like temsirolimus that's already been shown perhaps to be more effective in this poor risk group? But either way, if this is a newly diagnosed patient in my practice that walks in from off the street in Detroit and I say, what's my frontline therapy? I unfortunately don't have the luxury of providing that right off the bat. So I have to default to a TKI. However, where we have gotten smarter is that I take this data and a lot of the publications and that curve, and then I ship it off to the insurance company, and then I say, this is what I would like for my patient frontline because of the poor risk, and they are now starting to understand and comply and may even consider that. But that's a hard task because these are two very expensive drugs. So the financial toxicity of this versus that is now starting to really exponentially increase. So what do we do as a societal group in trying to develop combinations of IO and IO as we move forward? Because if you really wanted to, and we love doing this oncology, sometimes we make it a triplet. I don't even know how we would consider that. Part of the thing that's exciting about this combination, though, is actually not so much the objective response rate, but it's this. And it's been discussed and mentioned before in the other two talks, but I have to sit and take pause for a minute and say, that's 9% of a complete response. The last time anybody had that high of an anything was high-dose IL-2. And we got super excited despite, the toxicities are obviously still there. But you're talking 9% CR. We don't ever talk about that. We love talking about partial response, and that's still good. And we've talked about all these other things, but I want us as a group to focus on this potential of actually achieving a complete response and maybe doing a deeper dive on who those patients are. Perhaps they are the minimally, number of metastases or a specific subtype, maybe, 80% clear. I mean, taking a deeper dive on who those patients are and perhaps sequencing them and understanding them better would be really interesting, because that to me is the most exciting part about this combination. And obviously now the PD-L1 status is actually associated with a better outcome. It's like, terrific, thanks a lot. In the second line setting, a single agent Nivo, nothing. In the front line setting, combination, something. So greater than 1%, Look at this break in curve. Dr. Pontus, that's at least 101 of these laser pointers in the between. So is it important now for us, knowing that this combination is so financially toxic and potentially even side effect more toxic, should we figure this out in this instance, and would that be a better choice? And the answer may be maybe, because we don't really know. So at least for us now in the States, for second-line therapy, this is a done deal. This happens already in active practice. No one blinks. It's mostly covered. But here, I think the FDA is starting to realize, hey, we better sort of pay attention. Our European colleagues have figured it out, and others. So on December 13th, the FDA has already accepted the priority review. So this year in 2018, we may see that combination come to life. But I think we have to be a little bit more thoughtful, and perhaps this is our chance to go back to pathology and saying, maybe we really should do this PD-L1 testing. And I'm not saying which type, or, wouldn't even talk about, there's so many differences in terms of antibodies, but figuring out whether that would be our right approach. And as alluded to before, what about others? So the comparator here is sunitinib. And I argue that in the current data set, will that now change? Is your comparator in a frontline or second line setting, should this not be a TKI? Should that be another immunotherapy combination that we just talked about? Possibly. Should it be cabozantinib, based on the Cabo-Sun study? So one of the struggles, and I wanted to bring up this, is just that these trials are all in play, but everything changes. So now your comparator is a moving target. So at the end of it, when it becomes published, how do we apply it? And I think that's where we often struggle, because we start off thinking one thing, and then as time goes on and the accrual happens, your standards change based on emerging data, and then you're a little bit stuck. So in frontline therapy, I just wanted to put those are a lot of the clinicaltrials.gov number for other information, but I think it's pretty exciting times. Now, is there some glimpse? Here we know, as we talked about the emotion study by our previous speaker, that data is looking terrific, but do we have, a glimpse as to how it would work? Well, like it is in oncology, sometimes when you mix and match, it doesn't go so well. So here, you already have a glimpse of Checkmate 16. Now, this, obviously, the Nivo-Ipi combination, this was a 3-dose trial, was already in play. But if you look at this data with combinations, sunitinib and pazopanib, it wasn't so great. And I just want to highlight your serious treatment-related adverse events for the Nivo-sunitinib combination is at a whopping 42%. That is completely something almost ridiculous. And I think that is one of the challenges. It's just not efficacy, but what would be the cost of it to your patients, and for what? So we have to be very careful that this glimpse that was presented also by Betsy Plymack and Amin at the kidney conference is something that we have to look at, because this was a dose escalation phase 1. And I just want to hark back about 10 years ago when Brian Rini reported data on bevacizumab and sunitinib. Remember those days? We had issues with TTP and ITP many sort of months after that combination. So I remember that because in SWOG, I was supposed to be the one to move that forward into a phase 2, phase 3 combination till we saw the data and went, that's not going to work. So it's quite important to also look at the longer term perspective in terms of toxicity. So for second line therapy, the glimpse and maybe that little window into how first line therapy will show, I think we have to be skeptical and analytical in looking at the data. Now, other emerging trials, it's actually a pretty exciting field. You've got not just these are all of the immunotherapies, and again, it's not just the PD-L1s or the checkpoints, but here, for example, is a compound that targets OX40. and that targets the memory T cells that are exposed to these antigens. So a whole new way of looking at immunotherapy, and then of course the combinations of others. So again, here's your clinicaltrials.gov number if you're interested in learning more. But they are not all promising. So conceptually, it's exciting, but here's, for example, axitinib with a new compound called delaentorcept. I probably butchered that, I'm so sorry. But it's an activin receptor like kinase 1. I've never heard of it other than, oh yeah, it's a new generation of anti-angiogenic. So really quite important. And then lastly, let's not forget about immunotherapy in the adjuvant space. Just as we've heard recently with new data with sunitinib, the issue is, what do we do with immunotherapy? I mean, if anything, these guys have minimal disease. Should we try? So the Keynote 564 will address that with using pembrolizumab versus placebo as adjuvant. But then I ask you there too, should placebo be the comparator arm, or should we stratify to include sunitinib, especially in high-risk disease? This trial is already in play and accruing. What do we do with that? So something to just keep in mind. Anyways, what I was hoping to do today was just do a little bit of a deeper look at immunotherapy, not so much by mechanism, but more for practicality. So in the States, again, the only drug approved for second line is nivolumab, but keep your eyeballs open for 2018 and the rest of this year and even next year, and we'll see what the FDA weighs in on with regards to ipilimumab and nivolumab. But I think I highly encourage all of you to try to enroll your patients in clinical trials, because we'll never get this answer. I remember in 2004 being extremely excited with, the approval of sorafenib as our first line drug, and we've come a long way. But we have to be mindful of just not putting together random combinations or sequence, but really to be thoughtful also about who that person should be that should get that therapy. And what the heck do we do now in the area of personalized medicine and working with our pathologists to really identify that right patient? Thank you.
Thank you, Elizabeth. Any questions in the back, Dr. Ragavan?
Thanks, Elizabeth. Very nice presentation. We've heard 3 very nice presentations in a row. But there's kind of an interesting disconnect, and taking Edson Ponte's concern about how the curves need to be separated. You made the important point that there's a 9% CR rate. You didn't actually mention, although it was on the slide, that the median progression-free survival is only 7 months, meaning half the patients progress within 7 months. And those are completely consistent. The thing that I struggle with is your statement that you can't very well predict on the basis of PD-1, PD-L1 expression. And you're absolutely correct. That's what the data show. As I'm sure you know, Earl Burgess from our center presented at ASCO GU, work that he'd done in collaboration with Stephen and myself, that there is a disconnect when you look at PD-1, PD-L1 expression in the primary tumor versus metastatic deposits. So my question is this: because these drugs are so expensive, are we at a point where we should be mandating, wherever possible, biopsies of the metastases to look for expression before we start using these drugs? Or alternatively, doing a very careful retrospective analysis of those metastatic tissues that are available for biopsy purposes that have already been taken, so that you can refine whether, in fact, PD-1, PD-L1 expression actually does predict for such expensive drugs, whether they're likely to work or not.
Thank you, and I agree. One of the struggles, and I'll take a brief poll. In this room, who biopsies their metastatic renal patients at the time of either first metastasis or relapse? And there's your answer, Dr. Ragavan. So one of the struggles is academically, it's lovely. We work very well together with IR. The pathologist will yell at us if it's completely, crap material, as one of our pathologists said. One of the other issues for kidney cancer is it loves to go to bone. And we know just doing any bone biopsy how difficult that is to get viable material, even for immunohistochemistry. Forget even doing genomic analysis. It dies right upon decalcification. So I think the idea of most likely would be a retrospective look. The struggle I have is sometimes what's happening in academia is not mimicked at all in our community, and none of our community docs in the Southeastern Michigan group, as you know, we're part of a giant healthcare system now, they don't routinely do this. And their hit rate for even those biopsies is about 30%, where ours is about 70%.
I just have a comment regarding the comment of Dr. Derek, is that the problem with metastasis is that you are going to sample the one that you can. You don't know about the others.
Yeah.
And so you don't have the criteria defined that the one you biopsied are the one which is needed to know. So
Yep.
we need to go to another group, let's say, using another methodology, like, for example, the liquid biopsy, to have a better overall pattern of what kind of metastasis or metastatic tumor we are dealing with.
Yeah.
Because otherwise we are just sampling one of the metastases.
Right. Yes.
Thank you very much. We've been talking about metastatic renal cell carcinoma, but you have some words about adjuvant treatment. There was some new results with pazopanib saying that there is no place for pazopanib in the adjuvant setting. And I may ask you, outside clinical trial, what's your approach for patients with very aggressive disease? And do you have treatment with the sunitinib? What's your practice?
Right, so my general answer as one of the co-study PIs for an adjuvant trial through SWOG, which has been completed now, which is everolimus versus placebo, is to obviously, whenever possible, enroll in a trial. Short of that, I don't tend to provide adjuvant therapy for my patients. In the new data with sunitinib, I have discussions that are probably more geared to lead to that, meaning you have features of high-risk disease. There has been a trial that has shown this. There are considerable toxicities to consider for the year that you're on. And the two discussions that I personally have had with my patients, they both declined. They said, surgery is it. My surgeon says I'm cured. Thank you, Dr. Pontus. And that was that. So I think they hear about the side effects and they feel so good after the surgery that in both cases, at least my NF2, they declined. But it was a change in my own practice to actually have a discussion that's much more in depth about adjuvant therapy when I didn't used to prior to the STRAC trial. Right.
Thank you.
Right.
In the interest of time, we're going to move on to our clinical cases. Dr. Mancino.
And I invite Professor Antonio Rouge to join us on the table for the discussion panel, and Dr. José Nuno Marques.
So thank you so much for the invitation of being here presenting a clinical case, and without further delay, this patient came to us, to our center, in April 2013. He was a male patient, 63-year-old, the medical history of significant only in hypothyroidism under a very low dose of levothyroxine, no other significant oncologic familiar history. He was a non-smoker, and this history had started back in 2009 when he had a radical left nephrectomy. He had a very early stage tumor, a PT1B. It was a clear cell renal carcinoma, a Ferman 3. And when he came to us in April 2013, he was referenced to us by a surgeon from a private hospital due to 2 new lung nodules that appeared on the follow-up. So he had a 4-year interval time between the original diagnosis and the metastasis. They were both on the same side, so upper right lobe and lower right lobe. And we know that when we have oligometastatic disease, we need to both stratify the patient and think about a surgical or stereotactic approach. So Regarding this patient, when we stratified the risk, he was clearly a favorable prognosis patient. And regarding the role of metastacectomy or targeted therapy like SBRT, we don't have any prospective data. The only data that we have is retrospective. But we know that we have some factors that can help us in deciding if this is going to be a good option or a better option for this patient, or if it's not going to work. So we need to look at patient factors. It was a very good prognostic patient with an ECOG of 0. He had oligometastatic disease, single organ, no visceral disease besides the lung lesions, with a very long disease-free survival time, no sarcomatoid component. It was a clear cell. R0 resection was amenable, so he had, regarding the lung, less than 7 metastases, no mediastinal lymph nodes, and less than 4 centimeters. So we went on and did the lung surgery. Both nodules were renal cell carcinoma metastases, but unfortunately this was not a good option, so the patient 2 months later developed another 2 lung lesions that were both on the right and the left side. So at this time, with the disease out of control, our MDT panel decided that we should start targeted therapy because repeatedly exposing the patient to surgery perhaps was not the best option. So we started first-line sunitinib on the typical dose, 50 milligrams on the 4 weeks on, 2 weeks off schedule. Initially, on the first scan, he had stable disease with a toxicity profile that was tolerable. The only thing to say here was the hypertension that was grade 2, but controllable with only 2 classes of pharmaceuticals. And on the second scan, he had a partial response actually, but his TSH was rising, so we needed to increase his levothyroxine supplementation. Unfortunately, with the treatment and progressing along the months, at 9 months of therapy, the patient started to complain about the fatigue. It was actually interfering with his quality of life. So at this point, we had to reduce the dose to 37.5 milligrams on a 4 weeks on, 2 weeks off schedule. At this time, the patient remained on this dose, and fortunately, as we can see here on the scan, this was the initial baseline scan. This was the lesion that disappeared on the right lobe, and the left lobe also disappeared. Notably, this is a patient with a very low volume disease. So the patient started to ask us if he could stop the therapy. The side effects were, although controllable, interfering with his quality of life. So we don't have any prospective data again, but we know that this is a paper by Brian Rini and Bernard Escudier that shown that on patients retrospectively reviewed that had stopped therapy because of toxicity, patient or clinician decision, the patients that achieve complete response before the initial drug holiday can be associated with a longer time of therapy. So we decided to give him a therapy break. This was 1 year after he started the original therapy, and on the first CT scan, that was 4 months later, he had stable disease. Unfortunately, on February 2015, he had a very big progression, so here and here, and we had to restart sunitinib. But although this is true, he had almost 7 months of therapy-free interval that contributed seriously to his quality of life. So we restarted therapy, as you can see here. This lesion went from here to here, and the left lesion, that was this side, had a partial response also. So the patient on the same dose level achieved a partial response with a very different toxicity profile that he had initially. This was his first CT scan regarding tumor burden. The second CT scan continued to improve, but unfortunately, the third CT scan, although it did not comply with progressive disease, according to RECIST, the lesions started to increase in size. So we know that typically adverse events start by week 2 and worsen until week 4. The quality of life also has a cyclic pattern, so usually declines after the 2 weeks of therapy. And regarding the phase 1 trials of sunitinib, we know that the 2-1 schedule, that is 2 weeks on, 1 week off, provided prolonged drug exposure and a better toxicity profile. So regarding the PK levels also, blood concentrations achieve a steady state within 14 days, and actually after the 7-day stop they are still residual. So what we know also is that highest sunitinib exposure patients correlate with better OS and better PFS. So if we have a scheme that is theoretically providing increased exposure and that can improve toxicity, our decision here, this is regarding the response rate, was to increase the dose up to 50 milligrams, but on the 2-1 schedule. And actually, the patient had a 6-month interval between theoretical progression and true progression, but unfortunately 6 months later he had a new bone lesion, pain on the left hip, and lung progressive disease. So at this time we had 2 options regarding the patient. This is 2015. So we have axitinib and everolimus. They are different. This is not direct data. These are data from 2 different trials. This is the AXIS trial and the RECORD-1 trial. And I remind you that this was a patient that was now presenting with pain, for the first time symptomatic on this event. And when we have symptomatic patients, what we'll look to is overall response rate, so we can induce some kind of response that can improve his symptomatology. So when choosing between one and another, previous duration of therapy, this was a very driven disease by VEGF. He had a long exposure and response to sunitinib. Previous and current toxicity, that he had quite low toxicity, current comorbidities, and the need for overall response. So we went on to axitinib and we started zoledronate. And actually the patient had a very long time with axitinib, almost a year and a half, like 1 year and 2 months. Dose escalation was only possible to 5 + 10 milligrams, and this was limited due to hypertension that was controlled with 3 classes of pharmaceutical therapies. But then again, it did not allow us to go further on the axitinib dose. At this time, the patient progressed both on the hip and on the lung. And at this time, we had some problems accessing nivolumab. The molecule was approved, but it is currently on the reimbursement period. So we started everolimus, and curiously, the patient on the first cycle started to refer anorexia, a grade 3 fatigue, and he started to lose weight. So we did not tolerate everolimus. We had to stop him, and he had a very long time to recover from these side effects, but eventually this was possible. So on September 2017, we started nivolumab on 4th line. So as of now, the current status of this patient, he was lastly evaluated on January 2018. He has currently a dissociated response, so the lung lesions that were original are currently better, but he developed a new lung lesion. And the patient is referring that he is better from the pain on the left hip. So we know that this is a question with immunotherapy. We can have true progression or pseudo progression that furthers anticipates a partial or a complete response, hopefully. So we don't know yet if the patient is a primary resistant or if he's going really to be one of those 30% that benefit from nivolumab long term. So what we have now is planned for this patient is to repeat the CT scan in 4 to 6 weeks and see if this is a true progression or a pseudo progression. So I'm going to end with this slide. These are some key points that I'd like to point on this case for further discussion. TKI management regarding therapy holidays, yes or no. About the dose and the schemes that we use, 4-2-2-1, reduce the dose, reduce the scheme. So making the most out of first line is important. This was a very driven disease by VEGF, so we have now multiple options for second line. Are there still patients that are ideal for axitinib in second line? And what we do with pseudoprogression with immunotherapy? Are we going to rely on CTC counts for that? We know from melanoma and lung that this is going to be an issue. We know that the patients that have pseudoprogression in melanoma usually drop the CTC counts. And one question that we are asking currently in this, the MDT is, should we have done SBRT earlier in this patient? Is this still a possibility now? So thank you for your time, and this was my clinical case.
Good morning all. First of all, thank you for the invitation to be present here. I'm going to make some comments and I leave the questions for my subsequent speaker. This case, I think, illustrates what we are talking about all over this morning. Efficacy versus quality of life. and the balance that we have in all our days in our clinical practice between efficacy and quality of life. Also, the difficulty to have access to the innovation. You talk about the access to difficulties due to have access to nivolumab, and you use everolimus instead of nivolumab. That probably should be the better drug. And this sometimes happens to us every day in our clinical practice. We do not have the best drugs, only the drugs we have at our hand. And this puts some questions and some issues dealing with our patients. But your case demonstrates how far we are reached today. If we think about 5-6 years ago, we do not have this kind of treatments, and the patients die very sooner. We travel a lot. We reach with new drugs an extent of life of our patients with very good quality of life that increase the expectations, increase the way that patient wants that we do to him, and that put questions about the price, the drugs that we have available, and put issues that some time ago we do not have. So I'm going to leave questions to my subsequent speaker, and thank you for your very good clinical case. Thank you.
Dr. André Mansinho, thank you for excellent presentation. I think that it's interesting to stress that you did a nice discussion about the decision process to propose a patient with metastatic disease to a surgical approach of metastasectomy. Is a good discussion you did. You brought to this presentation the theme of the drug holiday, what we need to discuss currently. And you brought to the discussion of trying to hide sunitinib exposure to reach an improved response. And at last, you discussed the administration of further lines of therapy up till the 4th line. As Professor Araújo has referred, you put to the 4th line nivolumab, and we know what means offering the patients lately these new therapeutics. But I may say that I congratulate you. You did a nice discussion. And I would like to put some questions. And first, do you think that it's easier to reach higher sunitinib exposure with the schedule 2 weeks on, 1 week off, instead of schedule 4 weeks on, 2 weeks, and having the adverse events diminished too?
So regarding the dosage of the 4 weeks on, 2 weeks off versus the 2 weeks on, 1 week off, what we know is that patients are not equal, so they metabolize the drug on the different ways. So we can give the same dose to different patients and they have different AUCs. So, and we know that AUC correlates with response and probably not, overall survival and progression-free survival. So what happens with sunitinib is that after the week 2, the patients start to decline or to worsen of the side effects. So that is the critical point that furthers us to reduce the dosage earlier on. So if we change back to a 2-1 schedule, what we do is we can keep the dosage on the upper level and still improve toxicity while maintaining bigger drug exposure. So I think, yes, it's possible with this from our previous experience and some clinical evidence, some retrospective. The RESTORE trial is the only one that is prospective, that we can increase drug exposure while minimizing toxicity. So it's a strategy that we do currently. This was 2015. Nowadays, it's more frequent that we do this on our clinical practice.
Thank you. I would like to put you a question that probably will be more frequent. Do you know about the subject of the safety of treating these patients with radiotherapy when they are under treatment with ICIs or IOs?
Regarding IOs, there are some data from other pathologies that we can safely expose the patients to radiotherapy while there is currently being published a trial where they combined the phase 1 trial where they combined the two strategies, and it was indeed safe. Additionally, there seems to be an increase or a theoretical increased probability of response due to the abscopal effect. So radiotherapy with IOs is a very good strategy or possible strategy. Regarding TKIs, the toxicity that we induce on the skin, like with BRAF inhibitors on melanoma, is very high. With TKIs VEGF-driven, we can also increase some side effects regarding angiogenesis and cutaneous side effects, and its safety has not been established, so we usually stop the TKI to go to SBRT, as we don't have any data.
Thank you very much.
Okay, thank you all for the talks and your presence. We will re-adjourn in 15 minutes, so we will slash a little the interval.